When you think of like lasers in medicine, the image that usually comes to mind is one of just absolute sterile perfection.
Oh, yeah,
Like a
completely.
perfectly concentrated beam of light,
Right.
vaporizing a target with pinpoint accuracy, just completely isolated from the messy, unpredictable reality of the human body.
It feels very sci-fi, like, the ultimate clean precision tool.
Exactly.
Yeah.
But then you point that precision tool at the human microbiome, specifically the vaginal microbiome, and suddenly that clean narrative gets incredibly complicated.
It really does. It gets messy fast.
Right. So welcome to this deep dive. Today, our mission is to explore what happens when commercial aesthetics, cutting-edge cosmetic gynecology, and infectious disease all sort of collide.
And it's quite a collision.
Yeah. We're looking at everything from Mayo Clinic trials to like stark FDA warnings to answer one central, seemingly paradoxical question. So lasers and radiofrequency devices are becoming hugely popular for vaginal tissue rejuvenation, right?
Mm.
And they're even being studied to cure recurrent urinary tract infections. But there is a hard clinical rule sitting right in the middle of all this promise, and that is, should an active UTI be cleared before undergoing vaginal tightening?
Right. And exploring that question opens up this massive debate about how we treat our bodies, how these devices actually, interact with our tissue, and really the friction between medical innovation and clinical safety.
Yeah, totally.
It is a dense landscape of medical literature, no doubt. But there is a fascinating logic underneath it all once you look at the underlying biology.
Okay, so before we look at the risks of combining lasers and active infections, we really need to understand what is driving millions of women to seek out this technology in the first place.
Yeah, the demand is huge.
Because to figure out the risks, we have to know why we are, zapping vaginal tissue with lasers at all. And to understand this, we have to look at the conditions driving the demand, primarily genitourinary syndrome of menopause or GSM and vulvovaginal atrophy.
Right, VVA. And those are the clinical terms for what happens when a woman's body goes through menopause and, well, the lack of estrogen drastically changes the urogenital tissue.
It literally changes the structure, doesn't it?
It fundamentally changes structure. It thins out, it loses its natural elasticity, and the mucus-producing glands essentially just shut down.
And looking at the VVA survey data, the human impact here is just staggering. You've got 80% of women with this condition saying it negatively affects their daily lives.
Which is a massive portion of the population.
Right. And 75% report severe negative consequences on their sex life, and over a third report it literally just makes them feel old. It is a massive, often unspoken quality of life issue.
Yeah, it really is.
So the medical field responds with energy-based devices. We're talking about fractional CO2 lasers, brand names you might see like Mona Lisa Touch or Femilift, and radiofrequency devices like Votiva. But okay, let's unpack this because I'm stuck on the mechanism here.
Okay, sure.
I understand the tissue is thinned and painful, but the literature says these devices use, quote, controlled photothermal heating or microablative injury. How does causing more damage, like essentially intentionally burning the vaginal wall, actually fix thin tissue?
I know it sounds totally counterintuitive, right?
Yeah.
But it's based on how the body's healing cascade works. When the device creates these microscopic thermal injuries in the tissue, it tricks the body into a localized, intense healing response.
Oh, interesting.
Yeah, the thermal injury stimulates the fibroblasts in the tissue to ramp up the production of new collagen and elastin. It remodels the existing cellular matrix, thickens the vaginal wall, and basically brings back that lost elasticity and vascularity.
So you're basically forcing the tissue to regenerate by giving it a highly controlled microscopic wound.
That's it. It's like a localized structural reboot.
I hear the biological benefits, but honestly, looking at the NHS Scotland source, I am a bit skeptical about how this is being deployed out in the real world.
You're definitely not alone in that.
Right, because when I see ads for these lasers, they're often marketed under the umbrella of like rejuvenation or getting this idealized, neater look. Are we sure this surge in demand is about medical necessity, or is it just, high-tech societal pressure on women to alter their bodies to fit an aesthetic standard?
Well, what's fascinating here is that the tension you're pointing out is exactly what the medical community is wrestling with right now, because both things are simultaneously true.
Okay, how's that?
There is undeniably an aesthetic market driven by what they call vaginal relaxation syndrome, which is laxity from aging or childbirth. And the marketing leans heavily into that insecurity.
Yeah, absolutely.
But, you cannot dismiss the functional reality for women suffering from GSM. For them, the ability of these lasers to restore natural luterization, stop the severe tearing pain of dyspareunia during sex, and actually rebuild that tissue is profound.
It's life-changing.
Exactly. For a lot of patients, especially those who maybe cannot use hormone replacement therapies, this isn't about looking a certain way. It's about restoring basic, pain-free bodily function.
Which brings us to the core focus of this deep dive.
Mm.
Because we are manipulating very delicate, highly vascularized tissue, right? So a massive question arises.
Yeah.
What happens if a patient wants this procedure, whether for functional or aesthetic reasons, but they currently have a UTI? Like, if you're listening to this and you've ever dealt with a urinary tract infection, you know the absolute misery of it.
Oh, it's awful.
But if you have one, can you still get the laser treatment?
The answer across the clinical literature is an unequivocal, absolute no. The active UTI must be cleared before any vaginal laser or tightening therapy begins. Period.
And reading through the sources, that is a hard, non-negotiable rule.
Yeah.
I mean, in virtually every piece of clinical literature provided, from the UK's NICE guidance to the Mayo Clinic trial protocols, acute or recurrent urinary tract infection and active genital infection are listed as strict exclusion criteria.
Yes. They won't touch it.
The Mona Lisa Touch guidelines explicitly state it is, quote, unwise to undergo treatment with active vaginal or sexually transmitted infections. But let's dig into the why. Like, what is the actual risk?
It comes right back to the mechanism we just talked about. The laser or radiofrequency device is intentionally creating micro wounds in the tissue.
Right, the localized reboot.
Exactly. But if a patient has an active UTI, their urogenital tract is currently hosting an overgrowth of uropathogenic bacteria, like E. coli, usually.
Okay.
So if you introduce a laser into that compromised environment and create hundreds of tiny micro wounds, you are essentially opening up microscopic doors for those uropathogens to bypass the superficial cell layers.
Oh, man. So it's like trying to renovate your kitchen while the sink is actively flooding.
Yes. Great analogy.
You have to stop the leak before you put down new hardwood floors. Like,
Yeah.
if you tear up the floorboards while the water is still running, you are just going to rot the foundation.
And once that water gets into the subfloor, the foundation rots rapidly. The uropathogens ride right into the deeper layers of the tissue.
That sounds incredibly dangerous.
It is. The International Society of Cosmetology and Oncology, the ISCG, actually highlighted cases where this protocol was ignored or just, missed.
Wait, really? What happened?
Yeah, they detailed what they refer to as a Mona Lisa UTI event. So a patient experienced severe persistent urethral burning starting 2 days after her procedure.
Ouch.
When they reviewed the case, it was noted she actually had an active yeast infection that was being treated concurrently, like during the procedure.
Whoa, that's just a recipe for disaster.
Absolutely. The CDC classifies these types of procedures as clean contaminated, which means there is a baseline infection risk of 4 to 10% even under ideal conditions.
Wow. So if you manipulate already infected tissue, you aren't just risking a poor aesthetic or functional result, you are actively spreading the pathogens, exacerbating the inflammation, and risking severe post-procedural infections that can lead to chronic pain, bleeding, or like permanent scarring.
Exactly. It's just not worth the risk.
But this creates an incredible clinical catch-22 that I really want to unpack here. If you're someone who gets recurrent UTIs, clinically defined as 3 in a year or 2 in 6 months, the standard treatment is a heavy course of antibiotics.
Right, which clears the immediate infection but wreaks havoc on the broader microbiome.
Exactly. So here is the paradox. You have an active UTI, you want the laser treatment. The rule says you must clear the UTI first. So you take the antibiotics. The antibiotics wipe out the infection, but they also wipe out your entire protective vaginal microbiome. Now your flora is just like a barren wasteland, and you finally get the laser procedure.
To fix the tissue and theoretically fix the microbiome.
Yeah, it feels like we're chemically burning the village to save it, just so we can legally use a laser to rebuild it.
It is a phenomenal catch-22. And it perfectly illustrates why the Mayo Clinical trial is so significant right now.
Oh, the one comparing treatments.
Yeah. They are running a trial in CT 04301934 comparing fractional CO2 laser therapy against the current standard of care, which is topical vaginal estrogen. But they are specifically looking at menopausal women suffering from recurrent UTIs.
Okay, here's where it gets really interesting. How does that work biologically? Because once the active infection is cleared, how does burning the tissue with a laser actually stop future infections?
It's all about how the structural changes in the tissue dictate the microbial environment. So in a healthy premenopausal state, the vaginal microbiome is absolutely dominated by lactobacillus.
Right, the good bacteria.
Exactly. They produce lactic acid, which keeps the vaginal pH very low, usually between like 3.8 and 4.5. That highly acidic environment is incredibly hostile to uropathogens. It basically prevents them from taking hold and traveling up into the urinary tract.
But during menopause, when estrogen drops, the tissue thins out. And this is the key part from the sources, right? As it thins, the cells lose glycogen. And without glycogen, the lactobacillus starves and dies off. The pH rises, the environment becomes less acidic, and the uropathogens just move right in and set up camp.
You nailed it. So what the laser does is thicken that vaginal epithelium again. The controlled thermal injury causes the superficial cells to shed and new, healthier cells to form.
Okay.
And those new, thicker layers of cells are once again rich in glycogen. As those superficial cells naturally shed into the vaginal lumen, they release that glycogen, which directly feeds the lactobacillus.
Wow. So by structurally thickening the tissue, you are literally restocking the food supply for the protective microbiome.
And the clinical data supports this mechanism. One study showed that after laser therapy, the protective lactobacillus colonies massively increased, jumping from 30% of the microbiome to 79%.
Wait, 79%? That's a huge jump.
It is. The pH drops back down, the acidic shield is restored, and the uropathogens are crowded out.
So it really is a controlled burn. Just like a forest, once you clear the dead brush with the fire, the healthy ecosystem, the lactobacillus, has the rich soil it needs to return and completely dominate the landscape.
And just like a forest, once the healthy canopy is back, the invasive weeds can't get the sunlight they need to grow. If we look at the bigger picture, this represents a massive paradigm shift in how we might handle infectious disease in the future.
Right.
For a century, our primary weapon has been chemical antibiotics, just, dropping a bomb to kill the invading pathogens, with massive collateral damage to our own flora. Now we are looking at physical therapies, terraforming the host's tissue to empower the patient's own microbiome to defend itself organically.
It's incredible. You use a laser to physically restructure the tissue, which restores the glycogen, which feeds the lactobacillus, which lowers the pH, which stops the recurrent UTI. It's a brilliant biological domino effect.
It really is elegant.
But if these devices are practically miracle machines that thicken tissue, cure menopausal dryness, and stop the endless cycle of recurrent UTIs, why isn't every clinic on Earth doing this as standard practice? Why isn't this the first line of defense?
Because we are currently operating in what many regulatory bodies consider the Wild West of cosmetic gynecology.
Ah, the Wild West.
Yeah. The commercial marketing of these devices, specifically the lucrative appeal of terms like vaginal rejuvenation, has severely outpaced the rigorous clinical data.
And the regulatory pushback has been intense. In 2018, the FDA issued a very stark safety communication. They explicitly warned that these energy-based devices are not approved for vaginal rejuvenation or cosmetic vaginal procedures.
Right.
They cited serious risks like burns, scarring, and chronic pain when these devices are used outside of their approved specific surgical indications like destroying precancerous cervical tissue or warts.
And we see a very similar, albeit more measured, stance from NICE, the National Institute for Health and Care Excellence in the UK. They published guidance HTG 582 on transvaginal laser therapy.
And what do they conclude?
Their conclusion is that while the current evidence doesn't show any immediate short-term safety concerns, the long-term efficacy and safety evidence is inadequate in both quality and quantity. Their official recommendation is that these procedures should currently only be done in the context of formal research or strictly monitored clinical trials.
But the surgeons and practitioners actually doing these procedures are fighting back hard against those warnings. The ISCG blog, representing the International Society of Cosmetic Gynecology, argues that the regulatory bodies are basically throwing the baby out with the bathwater.
Yeah, they have a strong counter-argument.
They claim that these severe complications highlighted by the FDA are almost always due to untrained operators or poor patient screening, not like an inherent flaw in the technology itself.
And the ISCG makes a compelling point by citing some highly specific examples. They discuss a case where a urologist attempted to treat chronic urethral pain using fractional CO2 laser ablation.
Okay, and why is that bad?
Well, chronic urethral pain is notoriously difficult to treat, and you can understand a clinician's desperation to find a solution for a suffering patient. But the ICG points out there is zero literature, zero protocol, and zero biological rationale to support using a fractional laser in the urethra for that specific condition.
Oh, wow.
They flat out call it experimentation by a practitioner who lacked the necessary knowledge in the specific techniques and proper clinical indications for the device.
Right. They argue that if you have proper patient screening, like strictly enforcing the rule, that you absolutely must clear an active UTI first, and you have trained gynecological operators using the device for proven GSM symptoms, the procedure is remarkably safe. The ISCG's position is that by putting out these broad blanket warnings and dismissing the procedures entirely, the medical establishment is essentially abandoning millions of women who are suffering right now from very real, documented physical and sexual dysfunction.
This raises an important question, right? It highlights the classic tension in medical innovation. We have a technology that shows undeniable massive promise for conditions that have historically been ignored or severely undertreated. But because the commercial appeal of aesthetic rejuvenation is so incredibly lucrative, it invites bad actors, aggressive marketing, and poorly trained practitioners into the space.
Yeah, it makes sense.
The regulators understandably want 5 to 10 years of long-term randomized controlled trials before they give their blessing. But the patients suffering from debilitating dyspareunia or their 6th UTI of the year, they don't want to wait a decade for the final data to be published.
They need relief today, not when the trial concludes in 2030. So what does this all mean for you listening to this? If you are trying to navigate this space, we have miracle claims of restored tissue and cured infections on one side, and these Wild West FDA warnings on the other.
It means we are in a transitional phase of medical science, and extreme diligence is required. The potential of energy-based devices to alter the tissue environment is very real, but the respect for the biological ecosystem they operate in has to be equally real.
Let's summarize where this deep dive has taken us. Energy-based devices like CO2 lasers and radiofrequency treatments offer a truly fascinating potential cure for the debilitating discomforts of genitourinary syndrome of menopause and the endless cycle of recurrent UTIs. They work by causing controlled thermal injury that physically restructures the vaginal tissue, brings back vital glycogen, and remarkably restores the acidic shield of the protective lactobacillus microbiome.
That's the biological magic of it.
But because this is an active manipulation of a highly delicate ecosystem, incredibly strict clinical rules apply. Chief among them, the absolute non-negotiable necessity of clearing an active UTI before any laser treatment begins.
You just can't skip that step.
Right. You cannot intentionally create micro-wounds in tissue that is actively under bacterial attack, or you risk driving the infection deeper and causing permanent damage. And while the clinical results look incredibly promising, regulatory bodies like the FDA and NICE are urging extreme caution, reminding us that long-term safety data is still being gathered, and the line between clinical treatment and commercial aesthetics is currently, well, very blurry.
As we wrap up, I'd like to leave you with a final thought to ponder. We're just beginning to fully understand that our microbiomes are not just passive passengers riding around in our bodies. They are deeply physically connected to the architectural structure of our tissues. If a precisely calibrated laser can change the physical shape and chemical output of a cell wall just enough to invite back a healthy bacterial colony, could the future of treating all chronic infections look completely different?
Oh, that's a fascinating thought.
Could we eventually rely more on physical therapies, using targeted light, heat, and energy to build a better physiological fortress, than on the broad-spectrum chemical antibiotics we've relied on for the past century?
We started this deep dive talking about the sterile sci-fi precision of a laser beam clashing with the messy reality of the human body. But it turns out the goal isn't to use the laser to sterilize the mess. The goal is to use the precision of the laser to help the body's messy, beautiful ecosystem find its own balance again. Thank you so much for joining us on this deep dive. Keep questioning, keep learning, and we'll catch you next time.